Okay, so I'm going to finish our lecture. Um, so we've talked about cord prolapse several times, so we'll just run through this. Um, so if we do have a cord prolapse, that's where the water is broke and the cord runs through the cervix and gets compressed by the head. So we have to leave the compression off the cord. So we have to basically do a badge exam till we reach the head, and then we need to push the head up off of the umbilical cord. We can put this woman in Trendelenburg position, that is with her head down and her feet up. That will also help us to relieve the pressure off the cord, and then oxygen and rush to the OR. So this is what it looks like. So the water's broke, the cord comes rushing through, and then the head as the water leaves the uterus, the head slides down and compresses the cord. Management of amniotic fluid embolism. So amniotic fluid embolism is now called anaphylactoid syndrome of pregnancy. So they don't really know, what this is so much. They thought it was an embolism type thing. They're not thinking that it's an embolism type thing anymore, and so they're calling it an anaphylactoid reaction or syndrome of pregnancy. It is super, super rare, and thank God it is, because it is a very bad deal for both mom and babe. It frequently happens during or after birth, very shortly, very immediately after birth. We did have one case at community not several years ago, about 3 years ago. A woman was a patient at the birthing center, and she came in, she was laboring at home, went into the birthing center, and within 20 minutes of her arrival, they had her, they were shipping her to us because they knew something was wrong with this woman. And I'm not really sure what her dilation was at the time. I kind of feel like I remember, like, she wasn't even close to delivery. So it doesn't mean that it's only going to happen during the birth or during pushing or right after the birth. It could happen anytime that there is some sort of exposure to some sort of amniotic fluid or fetal cells or something. So anyways, when this happens, the woman has a sudden onset of respiratory distress, circulatory collapse. She could start hemorrhaging. If she could be sitting up 1 minute and talking to you, and the next minute she could be out cold. So it's very quick, and it is an emergency C-section. Okay. So, the woman will complain of chest pain if she is conscious, difficulty breathing. She'll be cyanotic, tachycardic. She is basically dying right there in front of you. So we need to support her cardiovascular or cardiorespiratory wise, and we need to get her to C-section. If we can catch these and we can support mom, even if we get the baby delivered, there's a lot of support to mom for her to recover from this, and sometimes we can't save mom, and sometimes we can't save the baby. This instance a few years back, at CMC, the baby did not make it, and mother did make it. We kept her at CMC for a while. We shipped her to St. Pat's, and then St. Pat's shipped her to either Spokane or Salt Lake. I can't remember which, but she was on dialysis. She was in end-stage renal and liver and they weren't thinking she was going to pull through. And the massive amounts of blood products they gave this woman it's just unbelievable. But it's a really bad thing, and thank God it's pretty rare. So now we're going to move on to CPD, or cephalopelvic disproportion. That's where the fetus is larger than the passageway. So basically, you're trying to, put a square through a round hole. It's just not going to happen. So for whatever reason, the baby's too big, or the woman has, birth canal issues, narrow pelvis. It might be, the mom thing. It might be a woman who has a normal pelvis but super large baby. So could be any one of those reasons. So with the CPD, we are looking at a prolonged labor, because that baby just doesn't descend, and we keep trying and keep trying and keep trying, and it's just not going to happen. So we are, putting this woman and baby at risk for problems if we continue to try to do this vaginally. Now it says here it's a difficult forceps assisted delivery. So, forceps and vacuum assisted delivery are supposed to be used to assist with a vaginal delivery, just a little more oomph, okay? Not like yanking a baby out of the depths, okay? We're not, when we use these instruments for delivery, we're just applying gentle traction to the baby with mom pushing. So if there's a CPD, if that baby's too big, or something's wrong with that pelvis and that baby can't come through, if a physician puts forceps on or a vacuum on and tries to force that baby out, we're going to hurt both of those people very badly. And there was a huge case a few years ago in Texas where a woman, she was like 4'8" or something, and her pregnancy was very large, and she asked for a C-section long before she went into labor. And the physician that she was seeing was not one who allowed for elective C-sections, like we had discussed today in lecture. Like, you can elect to have a C-section. That is your choice. But this physician did not practice that way, and he refused to do elective C-sections. So this woman went into labor. She went to complete. She started pushing. The baby wouldn't come. The baby wouldn't come. The baby wouldn't come. And this physician applied forceps to this baby and pulled with all his might, pulled this baby out. It was documented that he put both feet on the bed. So, this guy is really pulling. And he killed the baby. He severed the baby's spine. And the trauma, the physical trauma to the mom, and it ended up in a huge lawsuit. There's a big foundation against the use of forceps and or vacuum extraction. But if they're done appropriately, and they're a great thing. And it's also the nurse's responsibility to make sure that the physician is following the rules of using these. So if he starts breaking the rules, the nurse needs to intervene at that very, very second. So it can be quite an awkward, uncomfortable battle right there in front of the patient, but it needs to be done because these can be very dangerous. Now, some of the risks to the baby are cord prolapse. So how this happens is the baby is too big to even engage in the pelvis. So there's room for that cord to come rushing through. Excessive cranial molding, where we now are injuring the brain. Bruising on the head and face, we could cause an intracranial bleed. Nerve trauma, if this baby is actually um, allowed to deliver vaginally, we could hurt the nerves in the shoulder and the plexus injuries. So we just want to bag it and go to the C-section. It's too dangerous for both mother and baby. Now, they can do pelvic measurements to determine if the woman has an adequate pelvis. But most physicians don't do this a lot. They would just prefer to do a trial of labor. I don't know why. It's easy enough to do. So anyways, they don't do it. They just do a trial of labor. And ultrasound, they can also estimate the weight of the fetus to see if we have a really big baby. But what they ultimately do is a trial of labor. Because even if they do all these measurements, they could be off enough that they would determine that a vaginal delivery was not possible, and then go and do a C-section, and then sure enough, yeah, they probably could have done a vaginal delivery. So they just go for the trial of labor. All right, third and fourth stages, problems. So retained placenta. So third stage is when mom has already delivered baby, and now the third stage is the time it takes her to deliver the placenta. And that's usually done within 5 minutes, maybe 10 on average, but it could take up to 30 minutes to deliver that placenta. But one of the problems is she delivers the placenta and has retained part of the placenta, which causes bleeding. So when the placenta is delivered, the physician is required to examine the placenta to see if it is all intact. And if it's not intact, then he needs to go up and get the rest of it, okay? So she can have vaginal and cervical lacerations as well as perineal lacerations. So we'll talk about lacerations, I think, in another lecture, but the lacerations could be very severe and could cause a tremendous amount of bleeding. And then placental adherence. So the placenta does not deliver, and they have to go in surgically and remove the placenta. So again, retained placenta. So the placenta should be delivered by 30 minutes. If after 30 minutes the placenta hasn't delivered, then it's time to start thinking about a C-section, or not, I'm sorry, not a C-section, a surgical removal. They can try for a removal in the birthing room, but this is a very painful thing, and the woman is bleeding. So we can medicate the woman. Usually we give a big dose of epidural if she has one running. We'll give her a bolus. If she doesn't have an epidural, we might even give the Scaldemerol, something really strong for a manual removal. So if he can get it done in the birthing room, that's great. But while he's trying to remove that placenta, she is bleeding. So that's a problem. So we can't take too long to try to get this done. So cervical and vaginal lacerations. So you've got a firm uterus, you've got excessive bleeding, bright red vaginal bleeding, then it might not be coming from the uterus, it might be coming from her lacerations. So if that's the case, they can do a repair. Even if it's a cervical laceration, they can do a repair in the birthing room. It requires lots of pain medicine, maybe even a bolus of her epidural if she has one in, and they could try to repair that there. Otherwise, again, it's another surgical procedure where they go in and go into the OR to try to repair these. Okay. Now here's some bad things, other placenta problems. So placenta accreta, placenta increta, and placenta percreta. They're kind of the same deal except the degree in which they invade the myometrium, okay? So a placenta accreta attaches directly to the myometrium. That's the middle layer of the uterus. So you remember the uterus has the 3 layers. That's the middle layer. So it has penetrated through the endometrium and has attached to the myometrium. Now, so if the woman delivers vaginally and then they find out about this, then they have to go to OR, okay? They can try to remove an accreta. If the placenta detaches like it does normally, they can try to remove the placenta from the myometrium. However, do they get it all? Do they have retained adhered products, placental products? So it's kind of risky. So it may be unsuccessful. And if that's the case, then the woman's going to end up with a hysterectomy. They have got to get the entire placenta removed from the myometrium, or she will bleed and get infected, and she can't live with that, okay? So sometimes it requires a hysterectomy. Now, a placenta increta is, it doesn't just penetrate the endometrium and attach to the myometrium. It burrows through the myometrium, and yes, indeed, the woman will be losing her uterus to this, okay? And then the placenta accreta, or percreta, it penetrates completely through the uterine wall, and it could attach to abdominal wall, abdominal contents, okay? So here is another probably for sure hysterectomy, and depending on where it implanted to, she might have caused trauma to other organs. Okay, so if that wasn't bad enough, we have other placental problems. Circentrate placenta, circumvallate placenta, embellador placenta, and velamentous insertion of the umbilical cord. Okay, so with the circentrate, there's an extra lobe of placenta, and the vessels to that. So there's the main placenta lobe, and then there's this extra little lobe of placenta. Okay, so vessels are connecting both lobes, and those vessels are not within a cord. They're not within the Wharton's jelly. They're just being contained by the membranes, the amniotic membranes. So this is a bleeding problem for mom and babe. Circumvallate placenta. So you'll see some pictures of these, and you'll understand these a little more. But there's a little like circular ring type area on the placenta where the vessels are exposed. Then the placenta and the vessels are exposed. Okay. The Ballador placenta is the umbilical cord. Instead of being inserted at the center of the placenta, it's inserted kind of on an edge, okay? And the vessels are on the surface of the placenta, so these could be a bleeding problem. Velamentous insertion of the umbilical cord. Excuse me. So the vessels of the umbilical cord, they spread out away from the placenta. Okay, so let's just take a look at all these. So this is your circentrate placenta. So you see there's that extra lobe to the right, and then the main placental body to the left. And all those vessels between the main lobe and the little extra lobe, that's just membranes protecting those vessels. So those vessels are at high risk for being damaged and bleeding. So our circumvallate placenta, so you kind of see there that little ring or circle of like no membranes, and those vessels are exposed. So they could be easily damaged and cause bleeding. Here's our battledore placenta, where the umbilical cord is not attached centrally on the placenta. It's attached to the edge of the placenta, and so those vessels around there are prone to bleeding. And then our velamentous insertion. So you see the whole placenta there, and you see how the vessels kind of just pull away from the placenta before they're encased in the cord and the Wharton's jelly. So those all those vessels are just being encased in amniotic membranes, and they are very susceptible to trauma and bleeding. Oh, okay. So that's the end of the lecture. That was not much, oh gosh, not much longer. So I will get this posted. Thanks, guys.